infection of the kidney. Acute pyelonephritis is a bacterial infection of the kidney parenchyma, which can be life-threatening. And this is a complicated urinary tract infections. So urinary tract infections are classified as either complicated or uncomplicated. And generally, infections of the upper urinary tract are considered as complicated, and infections that involve the lower urinary tract are uncomplicated. So this is to illustrate what was just said. We have the kidneys, ureter, bladder, and the urethra. So any infection that involves the renal parenchyma, this is complicated. And then if you have an infection that involves the lower urinary tract, this is an uncomplicated urinary tract infection. So we move on to epidemiology. Acute pyelonephritis is common in females than males. And this is because females have a shorter urethra, so it makes it easy for organisms to ascend into the bladder. And if the infection is not kept at this point, it can ascend further up and involve the kidney, and this can lead to an acute pyelonephritis. There is limited epidemiologic data on the incidence of pyelonephritis in Ghana. So move on to risk factors. There are various risk factors that are involved in acute pyelonephritis. And the first on the list is a vesicoureteric reflux. And this is when there's an abnormal flow of urine from the bladder backwards. Normally, urine is supposed to flow from the kidneys to the ureter, through the ureter, and then to the bladder. But in vesicoureteric reflux, what happens is that the urine flows backwards. So it flows from the bladder up to the ureter and then to the kidneys. And this is common in infants and children. And it's usually due to an anomaly, a developmental anomaly that involves the vesicoureteric junction, which is located exactly at the point where the ureter joins the bladder. And this can be unilateral or bilateral. So when there is this backward flow of urine, it has the potential of carrying bacteria from the bladder upwards to the kidney. And this can lead to an acute pyelonephritis. The next on the list is a urinary tract obstruction. So if there's anything blocking the flow of urine, for instance, if there's calculi and it blocks the flow of urine, there's stasis of urine, which acts as a good medium for the bacteria to multiply, which can lead to an acute pyelonephritis. The third risk factor is a urinary tract catheterization. Urinary tract catheterization is supposed to be a sterile procedure. And if this is not done accordingly, the aseptic technique is not followed, there can be introduction of organisms during the procedure. And then also, another thing is that if there's any introduction of a foreign body in the body, or specifically if there's an introduction of a foreign body in the urinary tract, it acts as a good surface for bacteria to colonize on. And then when this happens, there's an increased risk of an acute pyelonephritis occurring if it's able to ascend upwards and involve the renal parenchyma. The fourth risk factor is in diabetes mellitus, especially in patients whose blood glucose levels are not controlled. When the blood glucose level is not controlled, it acts as a favorable environment for the bacteria to grow on. Also in immunocompromised states, since the immune system is compromised, there's this high possibility of the infection occurring, which can result in an acute pyelonephritis. The next risk factor is pregnancy. So in pregnancy, what happens is that there are hormonal changes, and these hormonal changes reduce the urinary flow during pregnancy, which increases the risk of infection. The last on this list is in sexually active individuals. So during sexual activity, during sexual intercourse, there may be minor urethral trauma, and if bacteria is transferred from the perineum into the bladder, it can cause a cystitis. And if the infection further ascends upwards and it involves the renal parenchyma, this can also cause an acute pyelonephritis. So the bacteria, we move on to etiology. The bacteria that are usually involved in the pathogenesis of acute pyelonephritis, these organisms are usually gram-negative organisms, which are usually from the bowel flora, and they usually ascend from the lower urinary tract, but they may also reach the kidney through the bloodstream, that is through hematogenous spread, though this is less common. So the most common organisms are E. coli, which is the most frequent cause. We also have gram-positive organisms. Again, these are less common. The most common ones are the gram-negative organisms. So examples of the gram-positive organisms are Staphylococcus aureus, Staphylococcus saprophyticus, and Enterococcus. With the clinical features, there's usually a classic triad of flank pain, which may be bilateral or unilateral, depending on the kidneys that are involved. There may be fever, and there may be costovertebral angle tenderness. So the patient may present with flank pain. There may be dysuria, there may be pain on micturition, there may be hematuria, and the patient can also present with increased urinary frequency. There could be agent. If there's a systemic infection, they could present with symptoms of systemic infection. So they may present with fever, nausea and vomiting, chills, rigors, or malaise. But what we should note is that usually in acute pyelonephritis, symptoms of cystitis are not always present. So they may present with just fever, and also on your examination, you might pick up renal angle tenderness or costovertebral angle tenderness. On signs of acute pyelonephritis, there may be fever. On your examination, you might pick up costovertebral angle tenderness, which is the same as renal angle tenderness. And the costovertebral angle is an angle that is formed by the 12th rib and then the spine on both sides. So it can be left or right. And usually what happens is that when you percuss over the costovertebral angle, tenderness is usually elicited, which indicates that there's a renal pathology. You might also pick up suprapubic tenderness on your examination. In men who usually present with symptoms of pelvic or perineal pain, we should always do a DRE, a digital rectal examination, to rule out an acute prostatitis. In females, we should always remember to do a pelvic exams to rule out a pelvic inflammatory disease as well. So we should also note that in infants and the elderly, with the extremes of ages, they usually present with atypical presentations. So in infants, they may present with either fever, they may also come with feeding difficulties or failure to thrive. In the elderly, they may just come with symptoms of systemic illness. So there may be fever, chills, or mental status change. We move on to investigations. So there are various investigations that we can do, though acute pyelonephritis is usually diagnosed clinically. So we can do a urine routine examination, which is also known as urinalysis. And this involves either the urine dipstick Then we can also do microscopy. So with the urine dipstick, there are usually various parameters, but in acute pyelonephritis or in urinary tract infections in general, we usually look out for two parameters. These are the leukocyte esterates and then nitrates. So the leukocyte esterase is usually a marker. It's usually done to help screen for pyuria. The leukocyte esterase is an enzyme, and this enzyme is usually produced when there is breakdown of white blood cells. So when you do a urine dipstick test and then the leukocyte esterase is positive, it indicates that there's pyuria. We also have nitrites, and nitrites is usually used to screen for bacteriuria, which is bacteria in the urine. So what happens is that most of the organisms that are able to cause UTI, they have this enzyme known as the nitrate reductase, which is able to convert. So when you take a normal urine sample, we have chemicals in it known as the nitrates. So the enzymes which are in the organisms that are able to cause UTI are able to break down nitrates, which is found in the normal urine, to nitrites. So when you do a urine dipstick test and your nitrate is positive, it usually indicates that there is bacteriuria. However, what we should note is that a negative nitrite test doesn't always rule out an infection. We can also do microscopy, and we are usually watching out for pyuria, which is white blood cells in the urine. And the usually for white blood cells in the urine, it is significant when it's greater than 10 micro per liter. We can also do a urine CS, a urine culture and sensitivity. And urine CS, this is usually to enable us know the exact organism that is involved. So if there is bacteriuria, yes, it will be able to grow, and then be able to know the organism that is involved, and then also to know the exact antibiotic to be able to use to combat that. And we should also note that urine CS isn't only indicated in patients who are going to be treated in an inpatient basis. So whether the patient is going to be treated in an inpatient basis or outpatient settings, we should always do a urine CS because of the possibility of antibiotic resistance. We can also do a full blood count. If there's a systemic infection, there would be elevated white blood cells. We can also do a blood CS, and this is usually for those who present with severe illness or sepsis. We have some imaging techniques that are also sometimes done, and these are just supportive investigations that are done. These are done to either rule out urologic abnormalities and then also to screen for complications. So they are usually reserved for those who are severely ill or those who have had persistent clinical symptoms despite 48 to 72 hours of appropriate antibiotic therapy. And the first is the CT scan, which is the gold standard. We can also do an ultrasonography as well. So there are various methods of collecting urine specimens. We have the clean catch technique. We have urethral catheterization and then suprapubic needle aspiration. So the urethral catheterization and the suprapubic needle aspiration, these are invasive techniques. The clean catch, which is the one that is commonly done, is a natural way of collecting a urine sample with minimal contamination. So usually the ideal way is to collect a clean catch midstream urine. Okay, so the ideal way is to collect a clean catch midstream sample of the first micturition of the day. So ideally, when the patient wakes up in the morning and is about to urinate for the first time, the patient cleans the genital area. And then if it's a female, she has to pat the labia majora and then take the sample. In taking the sample, we usually don't want the initial drops of urine that come out. That's the initial stream of urine. We usually go in for the midstream urine sample. This is because usually the initial stream would have some contamination from the urethra. So we usually go in for the midstream urine. Yes. So, and in males, in uncircumcised males, what they have to do is to retract the foreskin of the penis. And then also when the sample is taken, the sample should be sent immediately to the lab. It shouldn't be kept by the patient's side, because the more you keep the patient by the patient, the more bacteria continues to proliferate, because the urine is kept warm since it's in an airtight container. And this wouldn't really give a true picture of what is happening in the patients. The next one is urethral catheterization. And this method is usually used in patients who, for some reason, are not able to urinate. And then also in elderly patients who you wouldn't trust to do the clean catch method. Also in children, because they wouldn't be able to do the clean catch method. And then we can also do the suprapubic needle aspiration, though this is rarely done. It's usually done when there's no other alternative. So the presence of bacteriuria with or without pyuria in the absence of any symptom that could be attributable to a UTI is called asymptomatic bacteriuria, and generally doesn't warrant treatment in non-pregnant patients. So this means that if a patient presents to you and the patient doesn't have symptoms of a UTI, but then the patient has results which indicates that there is bacteria in the urine, you don't have to treat the patient. It is only in obstetrics, it's only in pregnant women that we treat asymptomatic bacteriuria. So we move on to treatment. Treatment can be done in either outpatient settings or inpatient settings. And then outpatient settings is usually for those who have uncomplicated infections. And oral antibiotics are acceptable for outpatient treatment. Either that, or the patient can also be started with a single dose of a parenteral antibiotic, an IV antibiotic, and then this can be followed by the oral antibiotics. With inpatient care, these are usually for those who are severely ill, or the elderly, or in pregnant women, or those who have comorbid conditions. And the supportive care that is involved, we usually try to maintain hydration by giving some IV fluids. And if the patient is vomiting or there's nausea, you can give some antiemetics. You can also give antipyretics if there's fever, and analgesics if the patient is in pain. So the mainstay of treatment is antibiotic therapy. And we usually start with empiric antibiotic therapy. And then if the results of the urine culture and sensitivity is in, we then switch to directed antimicrobial therapy. In doing this, we should be guided by our local antibiotic resistance patterns. Yeah. So for outpatients, the first line of treatment, the antibiotics that are usually used are the fluoroquinolones. We have ciprofloxacin, levofloxacin, and others. The second line, we usually go in for trimethoprim, sulfamethoxazole. For inpatients, first line, we go in for fluoroquinolones again, either ciprofloxacin or levofloxacin. For second line, we usually go in for the third generation cephalosporins, since most of the organisms that are usually involved are gram-negative organisms. So either ceftriaxone, ceftazidime. Others also go in for the second generation cephalosporins, such as cefuroxime. We can also give ampicillin, sulbactam, piperacillin, tazobactam, or meropenem. And another potent group of medications that can be given are the aminoglycosides, which includes gentamicin, amikacin, and tobramycin. But these aminoglycosides are usually reserved for those with life-threatening infections because of their potential nephrotoxicity. So we move on to complications. If acute pyelonephritis is not kept, it can lead to complications such as abscess formation. It can lead to sepsis. It can also lead to a multi-organ system failure. It can lead to an acute kidney injury. It can also lead to a chronic kidney disease. So how do we prevent acute pyelonephritis? We would have to increase our fluid intake, taking in at least 6 to 8 glasses per day. This is just to maintain bladder hygiene. And we would also have to maintain good personal hygiene, and then we don't have to postpone urination whenever we feel the urge to urinate. Thank you very much.
Thank you very much, Dr. Vivian, for an excellent job done. We're just looking at your references that you've gotten this information from. Excellent. Thank you for educating us on acute pyelonephritis. And I'm sure within 30 minutes, we'll be able to do this. And it's a reminder to most of us who have joined today regards how to diagnose acute pyelonephritis, and then regards the investigations as well, which are mainly supportive. So we'll go on to the question and answers, so that those who have questions and have put them up on the platform, we'll start with that. Then at the end of which, we will allow, if you have a question, you could electronically raise your hand, and then we would unmute you to be able to do so. So I will just go through what is in the chat box, and then we look at that. So the first question is from Basia. He said, why did we choose to do 1 gram BD dosing of the ceftriaxone instead of 2 grams OD of the ceftriaxone? I'm sure this is with regards to the case that you initially presented before you started with the literature. So any response to that, Dr. Vivian?
Okay. So we chose to give 1 gram BD. That is 1 gram twice daily, because we thought.
Yeah, so you did 1 gram BD, is that not so?
Yes.
Yeah, instead of 2 grams OD.
Okay.
Yeah, so he's asking any particular reasons for
that? No particular reason. I think it's the same.
Okay, great. Yeah, so I agree with you that you could do the single dosing of ceftriaxone or the dual dosing, that's the twice daily dosing of it. Both is accepted. Sometimes for patient convenience, people will go for the single day dosing. But again, for geriatrics patients, we may have to be careful with the single day dosing of the 2 grams. And so any way that you choose, this was a young patient, any of them that will go for is appropriate. Next one is from Dr. Farouk Sishu. Say, cool presentation, so quick. Well done. All right, thanks, Dr. Farouk. Then Basia comes again with, what's the role of ultrasound in the diagnosis of pyelonephritis? And what do you expect to see on ultrasound of the kidneys aside ruling out pyonephrosis? Do you have an answer for that, the role of ultrasound?
Okay, So just as I said, with ultrasound and with the CT scan, these are just supportive investigations. And for instance, with ultrasound, this can just help to rule out other differential diagnoses that you might have in mind. But because the kidneys are retroperitoneal, it's usually best to go in for the CT scan.
Great. So, Basia, just to add to that, pyelonephritis acute pyelonephritis is a clinical diagnosis. You really don't need an ultrasound to give you the diagnosis of pyelonephritis. And I'm happy that you brought this up because it's one of the things in my notes. A couple of patients we have seen, you realize that people send them in for ultrasound, and when they come back and they write pyelonephritis, we keep treating them. If the patient does not present with clinical features of pyelonephritis, the ultrasound doesn't tell you that it's pyelonephritis. The kidneys are retroperitoneal organs, like from basic anatomy. Ultrasound is not the best at diagnosing issues with regards to the kidneys, especially inflammatory conditions. Like we say, the gold standard for assessing kidney issues is usually the CT scan. The CT scan, especially with regards to infections or even complications of that. The ultrasound comes in handy to rule out anatomic abnormalities which predispose you to the urinary tract infection. That is the complicated one. That's the pyelonephritis that we're talking about today. And so, especially for acute pyelonephritis, it is your clinical acumen. It is your urinary that is supportive. It is your urine culture and sensitivity that guides your antibiotic stewardship and what next to give. So let's be careful in what we do. Like I always say, we don't treat laboratories, we treat human beings. So you come in, you have the clinical features, and then we ask you to go do some labs that then will probably confirm or rule in and rule out one diagnosis or the other, and further be able to rule out some complications or the other. So when we're asking you to go do an ultrasound, it is not to diagnose you of the pyelonephritis. It is to rule out an anatomic abnormality. That is one. Number two, it is to rule out a complication of the acute pyelonephritis, such as perinephric abscess, such as chronic pyelonephritis, like a rare one, but which is quite significant usually in our setting, xanthogranulomatous pyelonephritis. That's a form of chronic pyelonephritis. So really, we should be careful in what we do. It's not enough that you keep sending people for ultrasound, and then once you see, most of the times the sonographer will probably write query bilateral pyelonephritis or query pyelonephritis. Then we'll keep booming them with antibiotics. It's wrong. Also, it's not try to discourage patients as a general rule from just walking up into a lab and asking them to do some labs, and then they show it to you as a doctor, asking that put me on medicine or do this or the other. Usually, medicine is an order, so it's better you see a clinician first, get examined, and then based on the examination, we request appropriate investigations so that then it helps you probably in a better way rather than going to do anything and everything and may not even do the more important thing that you may have picked up from the clinical examination. So thank you very much for bringing this out. We don't diagnose pyelonephritis on the ultrasound. We use the clinical features. Anytime you have a patient with 2 out of the 3 triad that she has mentioned, you make the clinical diagnosis. The urine dipsticks are readily available, supposed to be bedside. If you do this and you have both nitrites positive and leukocyte esterase positive, you are almost certain that this patient has a pyelonephritis, and then you would treat appropriately. Also, please take note that, like she rightly said, with regards to the nitrites are usually produced by gram-negative organisms. Examples are what she gave, like E. coli, like Klebsiella pneumonia, like Proteus, like Pseudomonas aeruginosa, and all of that. And so there can be false negative, results for the nitrites in the setting of still having a pyelonephritis or even having a UTI in general. Because if this is caused by the gram-positive organisms, such as Enterococcus, like she has mentioned, such as Staph saprophyticus, like she mentioned in the presentation, obviously you would not, these organisms don't convert urinary nitrates to nitrites. And so your nitrite will be negative. And so if you are looking out for only the nitrites to be able to, you may be wrong in ruling out this. So it's better to be based on the clinical acumen, do a urine dipstick if that is readily available. And if you have any of these that is supportive, or even a urinary, once that comes in, then you are able to go ahead to start with the treatment whilst waiting for the urine culture and sensitivity to guide you. All right, so let's look at the next question. Bismarck is saying that please, with the inpatient management, first line and second line, is it per IV or orals? Vivian, do you want to take that?
Please, can you come again?
The inpatient management of pyelonephritis.
Yes.
Will you give the antibiotics intravenous or you give them oral?
For the inpatient management, yes, intravenous.
Okay, all right, great. Then the next one is, should fever be always present to make the diagnosis?
No.
Vivian, do you want to respond? All right, great. No. Then it's good you made it clear, because some decide to close their minds from pyelonephritis just because ultrasound came as normal kidneys. All right, I'm sure that's a follow-up to asking why clinicians would be using the ultrasound. So great, yes. Then Sani is in great presentation. Please, can you combine cephalosporin with aminoglycosides in treatment of pyelonephritis? Yeah, you can do that. And then please, in terms of the supportive treatment, can you give Nospa or maybe Alka-5 or Miss Potassium? So Nospa is an antispasmodic, isn't that so? So if the patient does have spasmodic pain, then of course, based on your clinical findings, it's not like a cast in stone. It's not like everyone would have to go on that. If the pain is like that, it's more of a spasm, like probably the pyelonephritis has a risk factor of, say, what do you call them? Nephrocalcinosis or renal stones. Typically, these patients will present with spasmodic pain. And if you're going to relieve that spasm, you can give an antispasmodic like Nospa and all of that. So it just be guided by the clinical findings. And then please, from your presentation, in terms of investigation, you don't talk about serum PSA, prostate-specific antigen. I think it's important for middle-aged males and above. Yeah, that's great. I think she mentioned it, more of the clinical features. If you look at clinical presentation, she spoke about in males, you need to rule out prostatitis as one of the things. Instead of just asking for just the PSA, it will be good to examine this patient. And based on your examination, your appropriate request for the serum PSA. So anybody who is presented with the LUTO symptoms, lower urinary tract obstructive symptoms, obviously you need to put your finger in there to be able to assess the nature of the prostate. Like in medical school, they always say, if you don't stick your finger in, you stick your foot in, is that also? So based on that clinical examination, you can go ahead to request for the investigations, including the PSA and even including the prostate scanning. Okay, the last one I have on the questions is, if after appropriate treatment and there's no improvement, what do you do next? Vivian, do you want to take that as the last question?
If
following the treatment, there's no improvement, what next? Yeah, so I guess, of course, following the treatment, if you're not getting any clinical improvement, you ideally would be guided by the culture and sensitivity results. One of the common causes of not having a good response is the fact that you are given an antibiotic that the organism is resistant to. And so if it's resistant to the antibiotics, it's virtually like you putting out some bread flour for the organism to keep enjoying. So it will be good to be guided by the culture and sensitivity results. And then as well, one of the things that you have to be careful about as well is a complication of like an abscess. Again, anytime, as a rule of thumb, anytime you have an infection complicating into an abscess, remember that the antibiotics mostly cannot penetrate the abscess wall. And so there will not be any clinical improvement whilst on the antibiotics. The way to go would be to let the surgeons have that abscess drained appropriately. So again, you may need to look further if there's no clinical improvement. One, is it that the antibiotic, the organism that you've picked up, the commonly E. coli or Pseudomonas, is it that it is resistant to the antibiotics that you are given? And if it is, be guided by the culture and sensitivity results. Is it that there's a complication that has already come up, like a perinephric abscess, like a chronic xanthogranulomatous pyelonephritis? Obviously, when it is, it becomes difficult and will not have any improvement, except, of course, having to bring in a surgical intervention, i.e. the drainage that I've already talked about. So you may need to look at both ways and then be guided appropriately. Also, could it be that it's one of your differential diagnoses rather than a pyelonephritis? Could it be an appendicitis that you are looking at? Could it be a salpingitis in a female? Could it be a pelvic inflammatory disease that, of course, when you did the renal angle tenderness, is rather that the person is having tenderness over those tubes that run there? So you may need to be guided again by these. So rule out the differential diagnosis, rule out the fact that it's probably that the organism is resistant to your antibiotics by getting the culture and sensitivity results, and also rule out a possible complication of an abscess. Okay, 2 more questions came up. Great presentation from Kofi Ofosu. Joined a bit late. Can the slides be made available? Yes, please. They would be made available. Kindly check on the YouTube channel, Ghana Medical Help. You find this presentation there with the slides. Then I think the same question came up from Muko Takrikitu. Okay. All right. So we are done with the questions in the chat box. If you do have questions or comments or suggestions going forward, could you kindly electronically raise your hand, or you could just unmute yourself actually, and then go ahead to ask your question. You could just tap on the unmute button, unmute yourself, and then kindly go ahead with your question or submission. Okay, whilst we wait for that, a couple of points that I made notes of that we will go through. Those who joined early to have looked at the case study that we put up, you realize that in the case that we had, this patient had clinical features of acute pyelonephritis. Again, emphasizing on the fact that it is important to look at the patient clinically. We do not treat laboratories. We treat human beings. Human beings present with clinical features. And so this patient did have clinical features of pyelonephritis. The urinary was suggestive of a urinary tract infection. Anytime you have a urinary that the pus cells are positive, the leukocyte esterase on a dipstick is positive. You have leukocyte esterase positive when you have 2 or more pus cells per high power film. Or if you do the urinary and then your leukocytes are positive, you are almost always there if the nitrites are positive as well. So if you have nitrites positive and then the leukocytes esterase or leukocytes positive, is highly suggestive of a urinary tract infection. And then with the clinical features, it is a UTI. if you have the flank pain, it is a pyelonephritis and you treat appropriately. That's how you go about it. The absence of both leukocyte esterase negative and nitrites negative is highly predictive of the absence of a UTI. So let's take note of these. You realize that in all of these that I've mentioned, we do not dwell on past cells. So it is not good. It is not a good clinical practice to treat people based on past cells. So someone can pass cells of 10, leukocytes negative, nitrites negative, has no clinical features. Just because the person woke up and decided to pass through the lab for them to do a lab test, and the leukocytes are 10, they'll put you on antibiotics. That is wrong. So there's what is called sterile pyuria. One of the common causes of that is medications, medicines that we give. We've actually had a patient like that. He was on a PPI, esomeprazole, 40 milligram daily for 1 month for treatment of, I think it was peptic ulcer disease. And this patient kept getting treatment of a UTI because the past cells were positive. The PPI, one of the side effects is pyuria. Same with NSAIDs. And then same with tuberculosis. So these guys will probably have passed going out. Like Vivian rightly mentioned, the only group of people that we treat asymptomatic bacteria is pregnant women because of the risk to the fetus, because of the risk to the pregnancy. So let's take note of this. Then the other thing I made note of is the urine culture and sensitivity. I think she rightly said that. So for every patient that we see, we would want, once you've made a diagnosis, a clinical diagnosis of acute pyelonephritis, in addition to your urinary, you want to do a urine culture and sensitivity, and even sometimes a blood culture and sensitivity. Again, it will be good to highlight our peculiar circumstances in rural environments because our culture results aren't so much to be relied on. The reason is that the cultures are supposed to be done on a couple of growth media. Like I always cite a common example, not everybody likes jollof rice. Not all the bacteria likes the same culture medium that we put in. Unfortunately, a couple of our labs do not have a lot of the growth agar to be able to grow these. E. coli likes the McConkey agar. And so if you don't have that, obviously the growth may not be too significant. And so your results may come back as culture negative. But truth be told that it is because we've not had the appropriate growth agar to grow these organisms. And so those of us in rural practice, it would be good to have your clinical acumen on point. Otherwise, you always have issues with the labs because either that the expertise is not there or we cannot even do some labs in the rural environment. Culture and sensitivity results in most district hospitals, we may not be able to, and a couple of them just as either 1 or 2 growth agar. Rarely would you ever find anaerobic growth in any of our labs around. So these are things that we should be careful about. Now, the more common thing that we do is the urinary. And unfortunately, we just, because of course, pressures of work and pressures at the lab, when patients present in, they are given bottles to go and urinate and bring. They bring it in, and of course, there are a lot of commensals that are being urinated in there. The preparation is not well done. Key, especially in the females. So it's supposed to be a clean catch, midstream urine, like Dr. Vivian rightly said. You need to educate the patient appropriately. So the midstream obviously will mean that once you start urinating, and best is the first morning urine, but it's not exclusive to that. It's interesting that a couple of labs will say that after 10 o'clock, they don't do urinary. That's again wrong because you can do a urinary at any time. It depends on what you are looking for. It's just that the yield in terms of picking up any of the things that we've talked about is higher with the morning urine sample, but it's not exclusive to the morning urine sample. So typically, you ask the patient that when you urinate in the first void, you start urinating, you let the few drops go out, and then in between, you take the middle of the urine, the sample, and then you allow the rest to go. Of course, Dr. Vivian beautifully explained why we have to do that. And the urine is actually supposed to be analyzed in 1 hour. This is one of the things that we have to highlight again. Unfortunately, a couple of times, because of the pressures at the lab again, the samples are left for a period of time. And so it will turn out a lot of false positive results. Again, calling us to be very 100% up with our clinical acumen. Otherwise, you treat someone who does not have a UTI. Then the second line of treatment of the UTI Dr. Vivian mentioned was the sulfadoxine pyrimethamine. Again, beware of G6PD deficiency. And so be guided by that. And then mostly we are guided by local antibiotic resistance patterns. Unfortunately, most of our hospitals don't have facility-based antibiotic resistance pattern. Please take note that in all of this presentation, we do not treat chronic pyelonephritis. That's a different ballgame altogether. It can be a complication of the acute pyelonephritis. Today's presentation was on acute pyelonephritis. And then the follow-up for the patients, very key, because once you've treated the patient of a pyelonephritis, which is a life-threatening, potentially organ-damaging infection, you need to follow the patient up to confirm that the organism has been eradicated. So these are things that we should be aware of. And so let's act on all of these. There are 3 questions that have come up. We have about 8 minutes to the hour to the close of this presentation. We'll quickly go through it. So Dr. Donato said, good presentation, Dr. Vivian. And Betty is asking, do alkalizing or alkalinizing agents have a role in the management of acute pyelonephritis? And she says, a great presentation, Vivian. Vivian, do you want to take a go at that? The use of alkalinizing agents in the management of acute pyelonephritis?
No, I didn't come across that.
Okay, so back in the day, they used to do that, but now it's discouraged. So if you have an infection, we treat you with the antibiotics that the organism is sensitive to, instead of making the medium less sort of bearable to the organism. Just kill the organism with the appropriate antibiotic. One of the things about the alkalizing agent is the predisposition to formation of urine stones. And so one of the things that has been frowned upon. Anytime you have acid mixing with a base, obviously you can form a salt. And so those organisms that are of acidic descent, once you add the base, you form a salt, and that is a stone. And that's one of the reasons that this has been frowned upon. Great. I don't see any other question in the chat box. I don't see any hand. We'll just give about 2 minutes if anybody has a question, a comment, a suggestion, a submission. Kindly do. Just put up your hand or just unmute yourself and then go ahead, please. Okay, I guess everybody is happy with your output, Dr. Vivian, because I don't see any hands up. And I would want to, on behalf of all the participants for today, thank you so much for the effort you put into this and the concise way you've presented it in less than 30 minutes and allowed a lot of time for the questions. Great job done. Thank you. Excellent. So, and also I want to thank all the participants today who have joined us for this educative session. Next week, we'll be looking at another topic. You'll find it on the same platforms. Thank you for joining us today. Have a great evening and God bless us all. Bye-bye. Sorry, just before I saw a last question. Please, what's the duration of treatment of acute pyelonephritis with fluoroquinolones? So it's the same duration, Dr. Abdul Salam, that Dr. Vivian put up about the 10 to 14 days. That should be fine. Okay, Mumuni says, thank you for the excellent delivery. Thank you as well. Bye-bye.